like to welcome very warmly all those who've been able to log in. We trust that you'll be able to gain a lot of insight and a lot of knowledge and skills by the end of this session. I can see a few of you who are regulars who've been here for most of our sessions. And even to those logging in for the first time, you're very welcome. And we thank you for joining us this evening. We know that everyone is busy, so we appreciate the time that you've taken to be with us, to join us for this session. We'll begin, and I know we are all set. Once again, thank you for coming for our session this evening. It is my pleasure to welcome everyone to today's session. My name is Ken Agutu, and together with my colleague Sam, we will be facilitating this evening's session. Today's session is part of the Tele-Education for Clinicians and Leaders in Africa, in short, Project TECLA Africa, which is an initiative between Making More Health together with Ashoka and two social enterprises from Africa, Chronic Drugs Medical Scheme, CDMS from Kenya, who are the hosts of today's session, and MDoc from Nigeria. We are running series on various disease areas. For now, we are on diabetes, and later we will handle hypertension and eventually move to other disease areas. And this will be based on the feedback that we get from you, our participants. So we truly appreciate your feedback, and hopefully when you get an opportunity, you can give feedback on the chat, but later on we will be sharing our social media handles that you can use to get in touch with us. Today's topic is acute diabetes complications, and it's the fourth of a 12-part series on diabetes. Our didactic speaker is going to be Dr. Rosemary Wanjiru, who once again has been kind enough to join us. I will introduce her at the appropriate time. We will have the didactic presented by her, and in that session, she will also present some cases that illustrate the didactic session that she's going to be handling. So welcome very much. The intention of these sessions is to create peer-to-peer learning across the many countries that we operate in and across the many countries represented on these calls. It brings together health workers from across the continent on a platform where they can share knowledge and experience on a wide range of health conditions through talks and care presentations from subject matter experts, and having these experts answer questions from participants. Presently, Nigeria and Kenya are acting as the initial hubs, and eventually we hope that we can scale these right across the continent. We have over 100 participating hospitals from across the continent. In Kenya, we've partnered with the Rural Private Hospitals Association of Kenya, in short, RUFA, among other partners whose representatives have been kind enough to join us this evening. We also have a great portfolio of experts from Kenya and other parts of the world. So these are some of the experts that are partnering with us to ensure that we get this learning across to you, our very kind participants. Please take note that Project TECLA Africa leverages the ECHO model. And what we do is we collect details of registration, participation, questions, and responses to our poll, the polls that we post. Your individual data will be kept confidential and handled by authorized personnel only. It will be handled by authorized personnel only, so there's no need to fear. This data may be used for reports, maps, communication, surveys, quality assurance, evaluation, research, and also to inform new initiatives that we can take care of in the future. This session will be recorded. We will be sharing a PDF version of the slides straight after the session. So you'll be able to have the slides with you, and we'll send these. I wish to outline our online protocol that will enhance your experience this evening. Number one is, please rename yourself by putting down your name, indicating what health facility you come from, and please do not use the model of your gadget. So if you are Oppo 520 or iPhone this and that, please just ensure you change and give us your name. Introduce yourself on the chat also by giving your name, your organization, and if you're from a health facility. And also on the chat, you can tell us how many people are logged onto the same device that you are on. This helps us in just getting to know numbers and just know the reach that we are able to experience. Please remain muted when you're not speaking, and in the event that you need to speak, then the host will unmute you and give you the opportunity to speak. Please use the raise hand feature in Zoom if you want to say something, if you want to ask a question at the right time. But you could also just, as we go along, just type out your question on the chat. We have a chat master that is going to pick those questions and share those with the didactic speaker at the right time. Our technical support team is available to help you in case you have any technological issues. And if you can look at your screen now, the contacts of Habil, Achieng, and Robert are shared there just in case you need to side chat one of them to help you with something. This session is projected to take 1.5 hours at the most, and the agenda will be shared on the screen now. Yeah, that's the agenda for this evening. You'll be able to follow that as we move along. And at this point, I would like us to get a word from the representatives of the social enterprises. I'll begin with our host, the CEO of CDMS, Sam Agutu, to say a word. He will thereafter invite the representatives of our partners, who will also introduce themselves and say a word before we move on to the main session. Sam?
Thank you very much, Ken, and good evening, everybody. Thank you for attending. We thank those who have been, on this journey with us, who have been attending the sessions, and we do believe that you found them informative and very helpful. And once again, thank you to Dr. Rosemary Wanjiru for working with us on this. My name is Sam Agutu. I'm the CEO of Chronic Drugs Medical Scheme. Our company does two things. We work in two areas. The one that we're handling right now is teleeducation for health workers. We work on improving health workers through digital upskilling. And therefore, as has been mentioned, we are currently on the diabetes series. There's a whole set of series, coming up over the next few months, and we do pray that you will continue to be with us. We also run a group procurement scheme for hospitals, and we will be, in the next 1 month, sharing out a lot more detail on how you can join and benefit from the benefits of group procurement. I'm not sure that we have representatives today from MDOC. Anybody from MDOC here? Adora? Maybe not. We have anybody from Ashoka or from Making More Health today? Right, I think if they join, when we're able to have them say a word or two later on. So thank you very much, Ken.
Thank you, Sam. You can also follow us on social media. This to the participants. You can follow us on social media, and those are our handles on social media. Please note those so that if you have any feedback, any suggestions, if you need to make any inquiries, then you can use those to reach us, and we will incorporate any suggestions in our future programs. At this point, I'd like us to post a quiz. There's what we call the precision quiz. This is for the purpose of testing your knowledge. It is not that serious, but please, I'd like to get everyone to attempt this quiz. At the end of this session, we will repeat the quiz so as to test our learning through the process of this session today. So please, let's have everybody attempting this quiz before we begin. We have 5 minutes to do this. There are actually 5 questions, so just read and attempt to answer these. We will repeat this quiz at the end of the training session, of the didactic speakers session, to just try and see how much learning we've been able to get. It's very important because it helps us to assess what level of knowledge we have before the session. Like I said, at the end of the session, we'll post the same quiz again, and then the didactic speaker will give us the correct answer, so to speak. Yeah. We have 2 minutes left, please. Let's go ahead and attempt the quiz. That will be the end of the poll of the quiz. Thank you very much. Ladies and gentlemen, it is now my absolute pleasure to introduce our didactic speaker for this evening. Our didactic speaker, many of you will be familiar with her, will know because she's been here before, is Dr. Rosemary Wanjiru. Dr. Wanjiru is a specialist at the Kenyatta National and Referral Hospital attached to the endocrine department, where she runs specialist clinics and supervises both undergraduate and postgraduate students. She has several years of experience and has practiced in many major hospitals across the country and carried out extensive research on diabetes, hypertension, and associated risk factors. Dr. Wanjiru holds a postgraduate diploma in endocrinology and diabetes from the Queen Mary University of London, a master's in medicine in internal medicine from the University of Nairobi, and both a Bachelor of Medicine and Bachelor of Surgery from the University of Nairobi. Her presentation, which will include case studies, case presentations, will take just about 30 minutes. And please now join me in welcoming her. And Dr. Wanjiru, you're very welcome. You're always welcome. And please take over the session.
Thank you very much.
Stop sharing, and maybe Dr. Chari, you can then share your screen.
Okay, thank you very much. You can view my screen now?
Yes, thank you.
Okay. Thank you very much, CDMS, for inviting me to give this talk and always allowing me to participate. Indeed, we have to do the education because we have a lot of diabetes patients living with diabetes, and they're not able to all come to the urban setups where we have most of the specialists. So I'm happy to see so many people interested. So today we're going to look at acute diabetes complications. We've had 2 other lectures prior. And my outline is that we're going to look at the types of the acute diabetes complications. We will have different clinical vignettes that will help us understand these presentations, where we look at the pathophysiology of each complication and also look at the treatment and try to see how we can prevent the complications. So when we talk about acute complications, what do we mean? Acute complications are those complications that will cause a patient to have a bad outcome or a bad morbidity or mortality if not detected early and not treated timely. So there are three main acute complications. And the first one is the diabetic ketoacidosis, which we call DKA. The second is a hyperglycemia hyposmolar state, HHS, previously known as HONC. That is that was the old name. The third one is hypoglycemia. And all of us who are practicing have come into contact with either a patient with these three complications. So the first clinical vignette presenting is of a 24-year-old male who has been known to have type 1 diabetes for the last 5 years and was brought to the casualty department with a reduced level of consciousness after having 2 days of fever and vomiting. She, however, has no history of travel. Physical examination found he had no history of travel. Physical examination found a young male who had no pallor, no jaundice, but had marked dehydration. His blood pressure was 90/50 millimeters with a low-grade fever of 37.5 degrees Celsius and a pulse rate of 106 beats per minute and a respiratory rate of 40. The lab investigations, we are not going to go through all of them, but I just picked the key ones, was that his initial run of blood sugar was elevated at 20 millimoles per liter. His blood count noted a white blood cell of 18 with a normal hemoglobin and platelet count. His renal chemistry was deranged with an elevated urea and creatinine, urea of 12, creatinine of 250. And I forgot to write the electrolytes where his potassium was 3.2 millimoles and a normal sodium of 140. His urinalysis noted a ketonuria of 3+, nitrites were positive, protein was nil, and he had glucosuria of 3+. His HbA1c was elevated at 12%. His thyroid function test and liver function tests were normal, and arterial blood gas noted that he had metabolic acidosis with a pH of 6.9, a low bicarbonate of 8, with a PCO2 of 25 and a PO2 of 88. So what is the diagnosis of this patient and what are the next steps? So this patient definitely has diabetic ketoacidosis, and we're going to go through the pathophysiology and how we came up with that diagnosis, and thereafter the management. So an introduction of diabetic ketoacidosis is that it occurs in about 15 to 85% of all our diabetes emergencies, and is the commonest cause of death in children living with type 1 diabetes or our young adults with type 1 diabetes. It rarely occurs in our patients with type 2 diabetes, but does not mean that it doesn't occur in those patients who have overwhelming infections, overwhelming conditions like presenting with cerebrovascular accidents or myocardial infarctions. Those ones can also present with diabetic ketoacidosis. The pathophysiology of DKA, that is our diabetic ketoacidosis, is that our patients usually have complete or relative insulin deficiency, but most of the time it's complete insulin deficiency. And if you remember on our first lecture where we were talking about what insulin does, is that insulin helps us to uptake the glucose after we eat. Therefore, if you have complete insulin deficiency, your body is unable to use the glucose and therefore has to revert to another energy source. And it breaks down your fat and muscles, therefore producing ketones. When it does that, you find that the ketones will accumulate and result in the acidosis due to the retention of the hydrogen. The resultant hyperglycemia will cause glycosuria, and the glycosuria causes urine water loss due to osmosis, and therefore the patients present with dehydration. And at the same time, when the glucose is coming out through the kidneys, we have electrolytes also being lost along, and that is why most patients will present with potassium deficiency. So it is very clear that the key thing is that they have insulin deficiency. Therefore, the patient reverts to another source of finding glucose or energy and breaks down the fat and muscle cells. Therefore, you have your acidosis. And what are the common causes of DKA? Most of the time, our patients who are newly diagnosed with type 1 diabetes will present with DKA. Patients who might forget or refuse to take their doses of insulin. Some might think that because they are unwell, especially our type 1 diabetes, when they have an acute illness, they might skip their insulin doses thinking that they will get hypoglycemia, and that predisposes them to getting DKA. Unknowingly, patients who use insulin that has lost its potency, you find that our patients maybe have stored their insulin in freezers, thinking that it will preserve their insulin, or maybe they have bought insulin that has had a poor cold storage chain, therefore it is not working well. If our patients have severe emotional stress, maybe death of a loved one, any acute illness, especially infection, or patients who present with strokes or myocardial infarction, trauma, like the patients who are involved in road accidents, pregnancy, any infection like pancreatitis, other endocrine pathologies like hyperthyroidism, and that's why you found that it is always good to find out how their thyroid function is, or acromegaly or Cushing's, and other idiopathic things like medications, especially our patients who are on high-dose steroids or are on thiazide diuretics, or are very sick and are requiring total parenteral nutrition. All these are possible causes of DKA or possible precipitants to patients developing DKA. And once you get a patient with DKA, you always have to try and find out what is the cause or what was the precipitant, so that you're able to educate your patient so that you can avoid a recurrence of the DKA. What are our symptoms and signs? They are varied, and they can include blurring of vision, dry flash skin due to the dehydration, patients who are trying to compensate for their metabolic acidosis. So they have acidotic breathing, which we call Kussmaul breathing, which is a rapid breathing and will have a fruity smell, nausea or vomiting. Some are confused. Others present with abdominal pain and may be mislabeled to have an acute abdomen, and some even land on the operating table, and that can be very fatal. Generalized weakness, polyuria, polydipsia. They might just present with fever due to the infection, or even loss of consciousness when they have severe disease. How do we diagnose DKA, or what are the lab findings? The D stands for the diabetes, so their sugar will be elevated to above 11, hyperglycemia. The K will stand for the ketonemia that we've talked about, or ketonuria. So now we have new glucometers that are able to assess the ketonemia, and if possible, that is a better way of assessing whether the patient has ketones, because we know that ketonuria can occur due to other causes like even starvation. We'll find ketonuria. So ketonemia or ketonuria. And the last one is acidosis, which we have to use an arterial blood gas, and you find the pH is less than 7.3 and the bicarbonate will be less than 15. So that is how we diagnose our DKA. So in our patient, you found that in our case vignette, his blood sugar was 20. He had ketones of 3+, and he had severe acidosis with a pH of 6.9. So definitely he had diabetic ketoacidosis. Now, how do we classify our DKA? We classify our severity as either mild, moderate, or severe, and that is dependent on the pH. Mild, the pH will be 7.2 to 7.3 with a bicarb of 10 to 15, while severe, our patient will have a pH of less than 7.1 with a bicarb of less than 5. Severe cases ideally should be managed in the ICU and require strict monitoring and review of at least every hour. But it does not mean that if you do not have an ICU setup that you cannot treat these patients. Is that just that it will be very difficult to manage, but we will, as we're going through the case, we'll find how we can manage. So what is the overview of management of DKA? we find that most people will be more worried about the hyperglycemia and will run to giving the patient insulin, yet that is the wrong way of treating this patient. The first step of treating DKA, or the next acute complication, which is HHS, is infusion of isotonic saline so that you can expand the extracellular volume and be able to stabilize the cardiovascular status. You find that some of these patients are quite fluid deficient, will require more than 9 liters. And if you try to bring down their sugar rapidly, they can go into osmotic or where they can get pulmonary edema or they can get cerebral edema, and you find that that will become fatal. So the first thing you need to do is to replace their fluids with isotonic saline. After replacing the fluid, the next thing you need to do is to correct the potassium deficit. When we talked about the pathophysiology, we found that they will lose potassium. And when you replace the insulin, especially when we use intravenous insulin pushes the potassium further lower. And therefore, if you have a low potassium and you give intravenous insulin, you have a risk of getting the patient to go into a cardiac arrest due or severe dysrhythmia. And this can be very fatal. Or you might find that your patient will go into a vegetative state if they have a cardiac arrest, because by the time you resuscitate them, they will develop hypoxic brain injury. So the first thing, isotonic saline, then you replace the potassium. And the last thing you do now is a low dose intravenous insulin, which should be administered intravenously in all patients who have severe DKA. But we'll talk about subcutaneous regimens for those patients who we cannot, for some reason, cannot give intravenous insulin, either due to staffing issues or lack of proper staff. We don't have enough staff to be able to evaluate. Now, the other management that we have to remember that we're not going to only look at the sugar, we need to look at the patient in totality. The first thing is to insert 2 large bore cannulas, and if not possible, the patient might need a central line. Then you draw blood for your blood count, your kidney function, UVCs, your arterial blood gas, your HbA1c or thyroid function test if possible. You need to draw blood for a blood culture because most of our patients have an underlying infection that has precipitated. You need to take any specimen that can also give you, if a patient has got any infection, like look at urine and do a culture. If they have maybe a diabetic foot or have any wound, you need to take a pus swab and take it for culture. Insert a urethral catheter for urine output monitoring. And if the patient is unconscious or has a low GCS, you need to insert a nasogastric tube so that you can prevent aspiration. And because you do not want to treat the DKA and find that the patient had an aspiration pneumonia and will have a long stay. And for these patients, we need to do hourly random blood sugar checks, and our kidney functions should be done every 2 to 4 hours, depending on the severity. You will note that I have indicated that for the blood gas, after the initial arterial blood gas, for follow-up, we do not need to do arterial blood gases. Venous blood gases are adequate, because right when you're doing now follow-up, you only need to look at the bicarbonate and the pH. So you do not need an arterial blood gas for follow-up. You only do an arterial blood gas as initial to do the diagnosis, and thereafter for follow-up, you go for a venous blood gas, because arterial blood gases are invasive and very painful. And if you do not know where they are very difficult to get. So a venous blood gas will do. So when we say the first thing is fluid replacement, and the fluid deficit should be replaced within the initial 24 hours. And if possible, your patient should be out of the DKA in the first 24 to 48 hours. And we use normal saline, the 0.9% normal saline, and you infuse 1 liter in the first 30 minutes. In the next 1 hour, you infuse another liter. And for the next 4 hours, you infuse 500 mLs hourly, meaning for the next 4 hours, you will infuse 2 liters. Thereafter, you infuse 250 mLs hourly until the fluid deficit is replaced. But remember, you have to individualize your patient. This is a patient who we are assuming does not have heart failure or a patient who does not have kidney failure. So you have to individualize your patient so that in case the patient has got heart failure or has got kidney failure, then you might not, you will not use the same regimen, and you will have to look at other measures so that your patient does not go into pulmonary edema. Once your blood sugar is 13 to 15 millimoles, then you need to change your regimen from normal saline to dextrose normal saline. And it does not mean that if you don't, your hospital does not have dextrose normal saline, that you cannot make it. What you do is that if you have normal saline, you're going to remove 50 ml of that normal saline and add that 50 ml of 50% to make your D5 normal saline. The reason why you change your fluid from normal saline to D5 normal saline is that the only way for you to come out of the ketoacidosis is by infusing insulin. Because we remember we said that the reason why you're going into acidosis is because you lack insulin. So your body is going to get another energy source by breaking down your fat cells or your muscle cells. And therefore, the only way to get out of that acidosis is using insulin. And therefore, if you continue with normal saline and your blood sugar has gone to between 13 to 15, you risk the patient going into hypoglycemia, which is another complication that we don't want. So once the blood sugar is 13 to 15 and the patient is still in DKA, you're going to change your fluid from normal saline to D5 normal saline. And you're going to run it at 250 ml per hour and adjust according to how the blood sugar is. Sorry. I'm not able to move my slides. So after the fluid, you go to potassium management. And we know that in some hospitals, you're not able to get immediate potassium levels. Maybe the lab closes at a certain hour, or you do not have the capability of doing the potassium. So if you're not able to get your potassium immediately, then you're going to add 10 milliequivalents of KCl to each 500 ml of normal saline, as long as your patient is able to, or you can confirm that the patient is passing urine. That's why we need a urinary catheter, or if your patient is not known to have kidney failure. So, but if you can get a potassium level, then if your potassium is less than 3.3, you hold your insulin and replace KCl at 20 to 40 milliequivalent hourly until your K is more than 3.3. If it is between 3.3 to 5.3, then you're going to replace your KCl 20 milliequivalent hourly. If it is more than 5.3, you hold your KCl. That is why you need to do your UECs every 2 to 4 hourly, so that you're able to tell how to replace your potassium. So the only time you're going to give 10 milliequivalent is when you're not able to get your potassium level, but you have to make sure that the patient has urine output and make sure that they do not have a history of chronic kidney disease. Otherwise, potassium is always required, because once you start intravenous insulin, it will push your potassium lower, and you do not want to suffer cardiac arrest because of hypokalemia. When we come to the insulin management, we have to monitor our blood sugar hourly, and you're going to start by giving 0.1 units per kg of either regular or soluble insulin as a start dose, and then give it hourly. So assuming our patient is 60 kilograms, what you're going to do is you're going to give 6 units as an IV start of insulin. That is our regular. Do not use your premix insulin or a basal insulin. You're either going to use the regular soluble insulin or our rapid acting insulins. You give it a 6 units start, and then thereafter you give it hourly. Then you're going to titrate your hourly dose. Our target drop is 3 millimoles per hour. You do not want a very rapid drop because of the risk of going into cerebral edema, and for the youngsters, pulmonary edema. Once the random blood sugar drops to below 14, then you're going to half the dose. So if you are giving 6 units per hour, you're going to half the dose to 3 units per hour. If you do not have the drop of 3 millimoles per unit per hour, then you are going to double the dose. So if you are given 6 units, then you double to like 12 units. But you have to monitor your sugar hourly. Once the sugar is less than 14, again, you're going to change your fluid from normal saline to dextrose D5W. Do not stop intravenous insulin until your DKA resolves. And how do we tell our DKA has resolved? This is by using an arterial blood, a venous blood gas, and finding that your bicarbonate is more than 15 and our pH has normalized. You also can use your ketonemia by checking our ketones in blood. We do not use urinalysis to assess whether our DKA has resolved, because one ketone body is broken down to a different ketone body. So you find that ketonuria persists for a long time before it clears. So do not use urine ketones to assess resolution of DKA. Another criteria to find whether the DKA has resolved is that your patient is able to eat. And once the patient has DKA resolution, then you're going to convert that patient to subcutaneous insulin, and make sure that when you're converting to subcutaneous insulin, you have an overlap with intravenous insulin for about 1 to 2 hours, so that you allow your subcutaneous insulin to start working. And how do you convert to subcutaneous insulin? You're going to either use your total insulin dose, that is, you're going to look at the last 24 hours, how much insulin did the patient require? If the patient required like 60 units, if you're using a premix, you're going to convert 2/3 of it in the morning and 1/3 you're going to give it in the evening. If you're going to give a basal bolus regimen, that is, you have a long acting and you have your basal, your boluses, you're going to calculate that, again, the total insulin that was required, and divide it into fifths. And you'll give 2/5 as your basal, and each fifth will be a bolus. If you're going to convert to a premix insulin, you'll give 2/3 in the morning and 1/3 in the evening. But remember, once your patient has resolution of DKA, you're going to overlap your intravenous insulin with subcutaneous insulin to avoid recurrence. Once you stop the intravenous insulin, it takes about only 2 to 5 minutes before the effect is cleared. So I'll go to our next case. And this is a 78-year-old male who was admitted to orthopedic ward with a fractured neck or femur and has been on traction for the last 2 weeks. Patient has been known to have diabetes and has been on follow-up with metformin, glibenclamide, and atorvastatin. And his last HbA1c, which was about 6 months prior, was 7%. For 5 days, he's been complaining of fever, productive cough, and general malaise. And on examination, he's found to be markedly dehydrated. He's found to have a blood pressure of 100/60 with a temperature of 37.1 and a respiratory rate of 38. He's confused with a GCS of 14/15, and physical examination noted that he has bronchial breath sounds on the right mid and lower zones. His random blood sugar conducted was HH and recordable. His renal chemistry is off with a urea of 24, creatinine of 340, with an elevated sodium of 150 and potassium of 5. His blood count noted an elevated white cell count of 24 and a platelet count of 600 with a low HB of 10. His arterial blood gas noted a pH of 7.3, PCO2 of 25, and a bicarb of 18. His urinalysis has ketonuria, which is trace, and glucosuria of 4+. His chest X-ray noted that he has consolidation on the right lower zone. So this patient has presented with what we call hyperglycemia hyposmolar state. And what is hyperglycemia hyposmolar state, previously known as HONC, if you read the old literature? It is a complication of type 2 diabetes. It is common in patients who either have undiagnosed diabetes or have prolonged loss of control. Rarely occurs in type 1. Patients usually have very marked hyperglycemia, up to 50 millimoles or even more. And the The risk factors are that the patient either has not been monitoring his blood glucose level or has presented with a severe infection like pneumonia in our case, or pyelonephritis, or other severe medical conditions like cerebrovascular accidents or myocardial infarctions, or severe stress, or drugs like alcohol or prescription medications like steroids. How do you diagnose HHS, and what is the difference of HHS from DKA? DKA, we said, is common in patients with type 1, but can occur still in patients with type 2. HHS is more common in type 2. The difference is that in DKA, it occurs over a very short period of time, maybe a day, if not hours. So a patient maybe skips the insulin dose for two insulin doses, and they're at risk of getting DKA. HHS is over a protracted time of maybe 3 to 5 days, like our patient was unwell for about 5 days. In DKA, we say D is for the hyperglycemia, K is ketonemia or ketonuria, and A is acidosis. And it's because of mostly absolute insulin deficiency. In HHS, they still have some insulin, so they will not present with acidosis, but it is not absolute that they will not present with acidosis, because they can present with acidosis from other things like sepsis, or if they have renal failure, they can present with acidosis. But mostly if they don't have sepsis or do not have renal failure, acidosis is not usually there. In HHS, they're very markedly dehydrated and usually have a deficit of up to 11 liters. Therefore, they're very, most of the time, you will find that they're very confused or moribund. Then the key thing of knowing whether your patient has got HHS or DKA is by calculating your serum osmolality. And what is serum osmolality? Is you get your sodium times 2 plus the glucose. So like in our patient, his sodium was 150. So 150 times 2 is 300 plus the glucose. His glucose was triple H, definitely it was more than 30. So 300 plus 30 is 330. So serum osmolality of more than 320 millimoles clinches the diagnosis of HHS. Other things you find is that their blood glucose is more than 30, they have an elevated urea. Electrolytes are variable dependent on other comorbidities or what the patient has presented with. The urine might have heavy glycosuria, but the ketones might be traced, might be there dependent on how the patient is. This is a complicated slide, but the key thing in HHS to remember is that because of their very high sodium level, you have to look at what their sodium is. And initially, how to treat their volume deficit is that you're going to initially give 0.9% normal saline. Once you get your sodium level, if you find it is very elevated, you find like it's more than 150, then you need to change and give 0.45% of sodium. That is half strength normal saline. Now, if your institution does not have half strength normal saline, then you still continue managing your patient. And what you're going to do is that instead of giving normal saline, you're going to give free water. And what is free water? You will just give 5% dextrose. And almost people will wonder, how do you give 5% dextrose, yet your patient already has a sugar that is maybe unrecordable? You're going to give 5, if you give normal saline with a sodium of maybe 160, then your patient is going to get worse and they're going to get CNS complications. So you're going to give 5% dextrose and you increase your insulin infusion. So that is the only difference between DKA and HHS. But in terms of insulin and in terms of potassium, it remains the same. So the mainstay of HHS is rehydration. In some patients, you might find that you might even stay even up to 12 hours before you commence your insulin, but the key thing is rehydration. And insulin is started at a lower dose. Instead of 0.1, you're going to start at 0.05 units per kg. So meaning that if your patient was about 60 kgs, instead of starting at 6 units per hour, you're going to start at 3 units per hour. And it's the same. You're going to give a start dose and then you infuse per hour. And again, the same. You're going to look at per hour how much sugar is coming down. And our target again is 3 millimoles per hour. So if you find it's not coming down by 3 millimoles per hour, you're going to double the dose, either come from 3 to 6. What about the subcutaneous insulin protocols? Because I've talked about insulin infusion, and I know most facilities do not, including where I work, our insulin pumps are limited. But what we usually say is that even if you do not have an insulin pump, it does not mean that you cannot give intravenous insulin. What you're going to do is that if you can get a Soluset, you're going to put normal saline inside like 500 ml. I mean, you're going to put your insulin inside 500 ml of normal saline. So assuming your patient requires 6 units per hour, you're going to put 30 units of insulin in that 500 ml, and then you're going to infuse 100 ml per hour so that you're able to give 6 units per hour. So if you have a Soluset, you're going to put 100 ml of that 500 ml every hour. And why you use a Soluset is because you're trying to avoid someone else coming and thinking this fluid is flowing too slow, and they increase the rate of infusion. So if you do not have insulin pumps, it does not mean that you cannot give the intravenous insulin. Now, if you're constrained either because you don't have enough manpower, what you're going to do is that you can give subcutaneous insulin. This, however, has only been validated for patients with mild or moderate decay situations. The ones with severe still require intravenous insulin. And the regimens that have been validated include giving the rapid acting, that is your soluble insulin, at 0.3 units per kg, followed by 0.1 units per kg every hour. So meaning if your patient is 60 kg, 0.3, you're going to give 18 units start. And then after that, you're going to give 6 units per hour until your blood glucose comes to 13.9. Remember, the fluid continues the same. The insulin dose will then be reduced to 0.05 to 0.1, and you administer every 1 to 2 hours until resolution of the ketoacidosis. So yes, subcutaneous insulin regimens have been validated, but these ones are only useful in cases where we have either manpower issues or when we had our COVID outbreaks and we were not able to don for all our patients. So those are the ones we were giving the subcutaneous insulin. So if possible, the best is still intravenous insulin. So when we come to our third case, we have a 45-year-old male with type 2 diabetes for the last 10 years. He's been using mid-start insulin, 20 units in the morning, 10 units in the evening, has been admitted with acute appendicitis and is planned for surgery. He has been NPO from midnight the previous night, and during handover, the patient was noted to be sweating and reported visual blurring and palpitations. And the night nurses informed that he received all his medications, yet he was NPO. So what do you do next? First thing is to confirm what this patient has, and most probably this patient, and what we confirmed is that this patient had hypoglycemia. So hypoglycemia is very common, and even in our patients, especially the ones on intense insulin regimens, they do present with hypoglycemia. And whenever you find a patient with hypoglycemia, a root cause analysis has to be conducted so that you avoid the repeat hypoglycemia. So because every time a patient gets hypoglycemia, what happens is that they risk going into arrhythmias, and they risk getting cognitive dysfunction, which is very common. They also have a risk of going into hypoglycemia unawareness. And in these patients, what happens is that they will get hypoglycemia and will not be aware, so they're not able to be proactive. So hypoglycemia has classifications where we have level 1, level 2, and level 3. And hypoglycemia is anything less than 3.9. So 3.9, the patient might be quite okay, but if it is less than 3, it comes to level 2 because this is serious and clinically important. Now, level 3 is any level where the patient has severe cognitive impairment and requires external assistance for recovery. What are the risk factors? They include some of the drugs that we use, and some of and other things like ethanol, beta blockers, quinine, ACE2 diabetes. Elderly patients are also at risk. Patients with intensive therapy, failure, liver failure, or retinopathy, where our patients are not able to see the dosage of insulin. Sorry, I dropped out. Let me share.
All right.
Sorry.
Thank you, Doctor.
Technology issues. Apologies.
Anashida, thanks.
Yeah, so religious fast like Ramadan or Lent, critical illness like malaria, or our patients in the critical care unit, they might go into hypoglycemia. The signs and symptoms are not exact and can vary between different occasions and different patients. And factors such as alcohol, fatigue, and beta blockers can make the symptoms to be difficult and can mask the symptoms. Like beta blockers will mask early warning signs. And when a patient is tired or is sleeping, might also be very difficult and to know whether the patient is getting the hypoglycemia. The other thing to remember is that some patients might get hypoglycemia at night and can tell you that they're getting bizarre dreams or waking up with headaches, which they describe as like having a hangover. So whenever patients tell you that, you need to tell them to check their sugars in the middle of the night or at around 2 to 3 a.m. The symptoms are like shaking, sweating, anxiety, dizziness, hunger, irritability, headache, weakness or fatigue, impaired vision, and palpitations. When they're asymptomatic, meaning that they recognize by self-monitoring, then what you tell the patient is that they need to be defensive and they need to stop doing any critical task that they're doing, either they're cooking or they're driving or they're using any machinery, and they need to ingest a fast-acting carbohydrate and thereafter adjust their regimen. If they're symptomatic, again, if possible, they need to check their fasting blood sugar, not the fasting, their random blood sugar, and again, ingest a fast-acting carbohydrate. And what we advise is for them to take a 15 to 20 grams fast-acting carbohydrate. And thereafter, they need to eat a long-acting carbohydrate to prevent recurrent symptoms. So what is a fast-acting carbohydrate? And this we need to empower our patients and teach all our patients who are on insulin regimens where they're at risk of getting low sugar. This includes 15 to 20 grams of glucose, 2 to 4 teaspoons of sugar, 175 ml of fruit juice or soft drink. And if it is soda, they need to take the regular soda, not the Coke Zero. 4 to 6 small hard candies, 1 to 2 tablespoons of honey, 100 ml of Glucosade. If you're in facilities where they have glucose tablets or glucogel, they could take 4 glucose tablets or 2 tubes of glucogel. So all patients on insulin should be walking around with either hard candy or some glucose so that in case they feel the symptoms, they are able to be defensive. What about our patients who have severe hypoglycemia, either are unconscious or unable to ingest? Then these are the patients who we give glucagon, and some facilities have the glucagon. And this can be injected either subcutaneously or intramuscularly at 0.5 to 1 milligram. And what you need to remember is that glucagon can give you marked nausea and even vomiting. So these patients need to be put in a recovery position. And once you give the treatment, you need to check again after 15 minutes to see if it has resolved, even the fast-acting carbohydrate. If you do not have glucagon, then we can give intravenous dextrose, and that is 50%. But the problem with 50%, it is very, what it does is that it is very viscous. Therefore, it causes thrombophlebitis. So you could dilute it, and what you can do, you can either give 70 ml of 20% glucose or 125 ml of 10% glucose. You can either put it in a peripheral line or a central line, but if you have a central line, you can just use the 50%. How do we prevent? Strategies to prevent hypoglycemia or even to prevent DKA or HHS is that patient education is key. Patient empowerment is key because you're with the patient only for about 15 to 20 minutes, but the patient is with themselves for 24 hours a day. So they need to be educated and empowered that how to adjust their medications and how to treat like hypoglycemia. Encourage the patient to have frequent self-monitoring of blood glucose. You cannot only rely on the blood glucose where the patient comes to the clinic. You need to know day to day what is happening. Again, giving flexible and rational insulin or other drug regimens, individualizing their glycemic goals. How you treat a 30 type 1 diabetic patient is not the same way you're going to treat a patient with known terminal illness, like they have CA pancreas and are having the diabetes. Again, professional.
Thank you for those who are posting questions and remarks, and also thank you to those who are attempting to respond on the chat. It's very exciting just being able to interact with everyone. Even as we wait for Dr. Wanjiru to log in again, which she is trying to, keep posting your questions and your comments, your feedback. It's very, very useful to us, not just for the benefit of all participants, but also for the benefit, our benefit as we engage in other initiatives in the future.
Apologies again, I dropped off again. So we just summarized the pathophysiology of the DKA and HHS. And for successful treatment of acute emergencies, teamwork is necessary and a must. You cannot manage alone. I, as a doctor, as an endocrinologist, require the help of the team in the ward. So this is teamwork. It's in both management of DK and HHS. And you do not give insulin if potassium levels are low. You notice that I did not talk about sodium bicarbonate. We do not give sodium bicarbonate unless the patient is collapsing because of either they have hypoxemia or have hypotension. Before, we used to give the sodium bicarbonate, but it's been found that sodium bicarbonate makes things worse. It will even cause your potassium to go down lower. So if you do give sodium bicarbonate, then you have to increase even the potassium supplementation. Insulin infusion is key in resolution of the acidosis. Hypoglycemia is not benign, and avoiding hypoglycemia is quite important because hypoglycemia will give you either cognitive dysfunction or will give you malignant arrhythmias. Patient education and engagement is key. Thank you, and apologies for the poor internet.
Wow. That's been delivered with obvious proficiency. Thank you so much, Dr. Wanjiru. Very, very happy that you were able to share that even in the face of technological challenges.
Thank you.
We have several questions on the chat, and I think that we will start with the ones on the chat because then we can take any other that comes. There's a comment or a question from Anthony Ochola. Something to be aware of is euglycemic DKA, especially with the rise of use of SGLT2 inhibitors for DM and heart failure. I think that is a comment. Thank you very much.
I just want to add, thank you, Anthony. That's a very key thing. You do get to glycemic DKA and you have to have a very high index of suspicion. The difference is that, remember when we talked about D having hyperglycemia, in your glycemic DKA, the sugar is normal. SGLT2s are very critical in giving euglycemic DKA. Other patients who might have euglycemic DKA include pregnant women or a patient who started giving themselves insulin at home. So they might have injected themselves insulin and a higher dose of insulin at home by the time they present. So having a high index of suspicion. Thank you for that. Yeah.
Thank you. There's a question that what is the protocol for the management of euglycemic DKA?
The protocol remains the same. The difference will be the fluid. So instead of giving normal saline, you're going to give like D5 normal saline, because at this moment, the patient's sugar is within the normal, but they're acidotic. So the potassium and insulin infusion remains the same. The only difference is the fluid. So instead of giving normal saline, you're going to give D5 or even 5%, depending on what level you have. Thank you.
Thank you. Thank you very much. There's another question. What is the chance of inducing hypoglycemia in such patients? How do you determine the amount of insulin to administer?
Very important question. And inducing hypoglycemia in the patient of these acute complications is very common. And that is why we advise on checking your sugar hourly. And once the sugar goes to between 13 to 15, you change your normal saline to D5 normal saline or D5% dextrose. So it is very common inducing hypoglycemia. So key thing of avoiding is regular checking and adjusting your insulin doses, so that if you find that you have rapidly reduced your insulin, our target is to reduce your sugar by 3 millimoles per hour. So if you find you're rapidly reducing, then you need to reduce your insulin infusion. Thank you.
All right. Then the next question is SGL2 and the risk of UTIs. How often should this be screened?
So whenever you're starting your SGLT2, you do not start SGLT2 in a patient who is not stable. So a patient who's admitted, unless they've been admitted because of heart failure. If they're admitted because of an infection, you want the infection to first be cleared. Then you're going to, if possible, you can do a urinalysis and screen whether they have a UTI. If they don't have, what you need to do is educate the patient that there's a risk of the UTI. So they need to be well hydrated. If they do get a UTI, then you need to treat it and see whether it will clear. If they continue getting, like you get patients who get recurrent UTIs, then you need to stop. Otherwise, they might get other complications. The other thing for SGLT2 is that because of the risk of going into euglycemic DKA, if they're going for surgery, you need to stop the SGLT2 inhibitor 4 to 5 days prior. Thank you.
Thank you very much. Any further questions? Any further questions? Your concern will be addressed, Raphael. Sam will talk about that a little later. Any questions for Dr. Wanjiru? And how do we manage fluids in a patient in DKA with comorbid CKD or heart failure?
So that will be on an individualized basis. And those are the patients, if possible, you send them to an ICU setup so that you use other methods. You're going to look at the urine in output, you're going to look at the CVP, you're going to look at how the heart is. So those ones are individualized. So you're not going to follow the same protocol as for this other patient, because the risk of taking your patient into pulmonary edema is very high. So it's on a patient-to-patient basis. So you won't follow the same protocol. So you look at the output, you look at the CVP. So you might give them half. There's no protocol per se. You're going to look at the patient and individualize.
All right. There's another question. Can the doctor clarify in terms of laboratory findings between DKA and HHS? Okay.
So in DKA, remember the D is hyperglycemia. The K will be the ketonemia or ketonuria. Ketonemia is checked in blood where your ketones will be more than 0.6. And nowadays we have glucometers that can check that. If you're in a facility that can, it is advised. A will be the acidosis, which we're going to use the arterial blood gas. So the difference with HHS is that in HHS, you will have the elevated blood sugar, but it will be very high, will usually be more than 30. In DKA, usually more than 11.1, they can get the DKA. The other thing is looking at your serum osmolality. That's the key thing. The serum osmolality, you're going to do 2 sodium plus the glucose. So if your patient has got a sodium of 160, it will be 2 times 160, that's 320. And if the random blood sugar was 30, will be 320 plus 30. You say serum is elevated, serum osmolality is elevated if it is more than 320. The acidosis, might be there in HHS, but not if the patient is just plain HHS, usually don't get the acidosis. Acidosis might be there because of either sepsis or either acute kidney injury. Ketonuria might be there dependent on how the patient presents. So the key thing will be these patients are markedly dehydrated. Usually their GCS is usually low because of the marked dehydration. They are mostly type 2 compared to type 1, which is DKA. And the serum osmolality is key. Thank you.
And one final question. Do we still have to consider SGLT2 in patients with BPH versus risk of UTIs?
Yes, SGLT2s are very good drugs, especially if you want cardiovascular protection or our patients who have proteinuria or have CKD, but the CKD should not be less than 30 eGFR. So if you would want to consider maybe managing both conditions at the same time, your BPH, if they do get recurrent UTIs, then I would advocate for you stopping the SGLT2. So you have to individualize again your patient. If the patient is going to benefit from SGLT2, I would rather the patient is on SGLT2, but if they're going to cause more harm, either they are getting hypotension or they're getting recurrent UTIs, then I'll avoid. Thank you.
Wow. Thank you so much, Daktari. It's been an absolute pleasure just listening to you and you breaking down this into chewable pieces for all of us. Thank you very much. We will now do the post-session quiz, and kindly attempt the quiz again, same quiz. Let's just see how we've done after the presentation. And then after that, the doctor will take us through the questions. Then we will close. As usual, we intend to close by 7:30, 7:30. I can see people are answering with a lot of enthusiasm. Let's see more people giving answers, please. Can we see more people answering? Please attempt the quiz. Simple questions, same questions we had seen earlier, but these are now coming after the didactic presentation. We have 2 more minutes. All right, I think we'll end the poll now, the quiz. Dr. I would request that you give a response to one final question. There's a question, a type 2 DM patient on oral hypoglycemic drugs and develops DKA. Do we switch to orals when sugars get to 14 with soluble insulin, or do we do subcutaneous insulin?
If a patient develops DKA, and even if they were type 2, it tells you that that patient has got insulin deficiency. So that is a patient who on discharge, I will switch them from orals to insulin. So once I manage the DKA, dependent on how they present, I might manage them with the IV insulin, and then subsequently they will go on subcutaneous insulin.
Thank you. Thank you very much. So can I request that you take us through the quiz?
Yes. So I'll start with the first questions. Is that the following are acute complications related to diabetes, except This was straightforward, and I can see everyone who answered got it right. We said that 3 complications are our DKA, diabetes ketoacidosis, hyperglycemia, hyposmolar state, and hypoglycemia. Acute pancreatitis will be a precipitant to getting DKA or HHS. So got it right. Then the next question is, where did it go? The following can be used to treat hypoglycemia of 2.3 millimoles in a conscious patient, except. So remember what we said is that initially you need to give 15 to 20 grams of a fast-acting carbohydrate. Now, the reason why A is the right answer, glass of warm milk, is not given, is that the warm milk will require to be digested. So the hypoglycemia will continue. So initially you need to give them 15 to 20 grams of fast-acting carbohydrate. So 2 hard candies, glucose, or half a glass of regular soda. If I had written of Coke Zero, that would also be wrong. So glass of warm milk was the answer we were looking for. The third question, in management of diabetic ketoacidosis, avoid intravenous insulin if the potassium is less than 3.3 was the correct answer, because we said intravenous insulin pushes the potassium downwards further. So if the potassium is already less than 3.3 and you give intravenous insulin, you risk the patient going into dysrhythmia or going into a cardiac arrest. Give potassium supplementation to all patients. If the patient has got renal failure or are anuric or their potassium is more than 5.5, you will not give potassium supplementation. I've seen this in some critical care units where they starve the patient until the sugar normalizes, and that is wrong. If you starve the patient, what happens is that you starve the patient and they continue going into a stressful moment, and their sugar continues going up. Fluids are not useful. Fluids are definitely useful. So the correct answer was avoid intravenous insulin if the potassium is less than 3.3. Then the following are possible precipitants to development of DKA, except inadequate insulin is a precipitant. Steroid use is a precipitant. Normal saline infusion, total parenteral infusion. So the correct answer is normal saline infusion. Remember, we were using normal saline to bring down the sugar. The rest, inadequate insulin, steroid, or TPN, can all precipitate. Then the following investigations are useful in the initial diagnosis of DKA or HHS, except. The key word here is the initial. So random blood sugar, definitely you want to find out whether the sugar is elevated and to guide you on how to give the fluids and how to give the insulin. Arterial blood gas, you want to find out if the patient is acidotic. Urinalysis, you want to find out whether they have ketonuria. A CT brain is the correct answer. It is useful, especially if a patient has had a CVA, but not for the initial diagnosis. Initial diagnosis, you require the other. And I think the quiz is over. So thank you for answering. Over to you, Ken.
Yes, and thank you for responding, and thank you for explaining those. I think that's been very clear. And as we are coming to the end of this session, I'll give you a brief moment just to say something about CPD points, because I know it's a point of concern. But I'd just like to thank everyone once again for turning up. Our next event will be on Thursday, the 26th of May. That is the last Thursday of next month. The topic will be diabetes, chronic complications. So chronic complications in diabetes. We will advise who the presenter will be in due course. And as usual, we'll begin at 6 and the session will go up to 7:30. I know there's been a request on the chat for us to begin these sessions at 7. There's been a lot of debate on what the best time is. We will consider that request, but at least for the purpose of the next session, we will begin at 6 like we did today. And like I said, we will advise who the presenter will be. If you have any topics that you'd like us to present in the future, please feel free to post these on the chat, or you can share these on our social media pages. Once again, we will, I think it's now been confirmed, the next event will be presented by Dr. Eric Njenga. Thank you for sharing that, Sam. And the topic will be chronic complications in diabetes. At this point, I'll ask Sam to say something about CPD points, and then we can call this a day. Thank you.
Thank you very much, Ken. Thank you for all those who have asked about CPD points. Now, for nurses, we receive a code from the Nursing Council of Kenya, which we will then share with each one of you who registered as a nurse and attended today's session. So we will share that code with you by end of day tomorrow, and you will then be able to, self-administer the CPD credits. Now, for the clinical officers, we engaged with them last week and this week, and they told us that all we need to do is to submit the list of names of the attendees, all right? I saw a question or a concern that we do not have your registration numbers or your license numbers. Now, the instruction they gave us was just submit the names. But if it is necessary, therefore, for the license numbers or the registration numbers to be used, I believe we can, we'll be able to contact you through your registration details and get that information so as to forward it to the clinical officers council. This is the first time we're doing it for the clinical officers. They had a problem with the portal last week, and therefore we were not able to communicate this information to you earlier. But I do hope that each one of you has indicated your profession in the registration details. Thank you. If anybody has any further queries, maybe you can just share it in the chat.
Yeah, thank you so much. I can see that someone has asked that we consider sickle cell in the next webinar. We will consider it, not in the next one, but for sure we will consider it in the not too distant future. Thank you. And at this point, I would like to thank everyone again, and we've come to the end of our session this evening, and hope to see you again next month. Thank you.
Just a word to Raphael, the one who asked the question. Maybe we could even engage or side chat separately if you need any further clarification. So I think if we can be able to just have our videos on and give a very big thumbs up and a clap to Dr. Wanjiru. Thank you very much, Rosemary. Let's all give a big clap to Dr. Wanjiru.
Thank you.